Good morning and good afternoon, AHCJ. Thank you so much for joining us for this important webinar, Reporting Accurately and Ethically on Opioid Addiction. Before we jump in, I wanted to remind y'all that there is also a webinar on Wednesday. It's posted on our site. It's called The Immigration Health Beat, a Practical and Ethical Guide. Today's guests are Ashton Mehra, a journalism professor, a journalist. She's executive editor of 100 Days in Appalachia. She is a native of West Virginia. She is co-founder and co-director with Jonathan Stoltman on reporting on addiction, and she teaches at the journalism at the University of West Virginia. Y'all can read the more elaborate bios on the site. With her, again, co-founder and co-director of Reporting on Addiction, Jonathan Stoltman, who is a developmental psychologist and researcher on opioid addiction and recovery, and some other topics, including areas of reproductive health, health stigma, etc. He's also director of the Opioid Policy Institute. Ashton and Jonathan, over to y'all.
Great. Thank you, Katti. Let me throw these up. Awesome. Cool. So thank you, Katti, and thank you, AHCJ, for having us today. We're reporting on addiction. This QR code will take you to our website, but it's really easy to remember. It's also just reportingonaddiction.org. And talk a little bit about our group and the work that we've been doing since we launched in 2020. We work with 3 different domains. So we work with professional journalists like yourself. We provided support to over 50 journalists one-on-one. So if there's a story that you're working on, that you're pitching, that you're in the middle of writing, or that you got a lot of feedback on afterwards, we help with all of that, anything from pitch to publication and beyond. We do newsroom trainings and organizational trainings like this, and we've been in 10 newsrooms. So if there's a newsroom that you're at that you think would benefit from this information, we'd be happy to work with you further. We also work with educators and students. So we know that some journalists are also journalism educators like Ashton. And if you are working with students, or if you have this like amazing journalism teacher that you used to love and you stay in touch with and they help with stuff or whatever, we're always looking for new schools to get into. We're in 13 schools right now across the country, so we're really proud about that work. And the goal there is to equip those next generation of journalists with some of this information. And then we work with experts. So that's folks like me. So those are defined as experts through training and experts through experience. And we have trained over 100 experts to work with y'all as sources, to feel more competent in sharing their knowledge with journalists. And then also they are available on our website. So if you're looking for sources for stories, Ashton will talk to you a little bit about how to find those folks. So why care about addiction reporting? Obviously, if you're here today, you care a little bit about addiction reporting. But addiction, of course, intersects with so many beats. So we know today we're talking with primarily healthcare journalists. I know that you focus in health and science, I would imagine. And addiction, whether you've covered it in the past in your other beats or you're doing other beats in the future, taking this same lens of how we report on addiction and treating it as a health condition across all of the different beats is really what we're trying to encourage the media to do. And we'll talk to you today about how to improve that reporting across all of these spaces. But we, of course, recognize that it's not just a health journalism issue. It's covered in arts and entertainment, technology, politics, all of those things. So again, if you're in a newsroom and there's a reporter that's reporting on this topic, providing those resources for those journalists so that we can help them as they're covering this story, as they're covering their stories in those other domains would be great. So I do a little bit of what we call Addiction 101, and this is level setting or baseline setting for the group, just to make sure everybody's up to speed with the different topics. So when we're talking about addiction and stories about addiction, we really want to think about it throughout all of the different domains associated with addiction. So that's prevention. So these are prevention programs that are rolling out in your communities. You see a lot of this happening and conversation about this happening right now with the opioid settlement money. How do we spend this money to prevent future addiction? Then there's, of course, the narratives around addiction itself, which we'll talk a little bit more about today. And then we also have stories about harm reduction, treatment, and recovery. So we'll reference all of these things. But when you think about reporting on addiction, we provide help throughout all of those different types of stories across all of the different drugs. So it's kind of a lot, but we're not going to go into all of those things today. But if you're writing a story on alcohol, we can help you out with that. When we're talking about addiction, we're primarily our group's focused on substances. We also can help folks if you're doing like stuff around like online sports betting or all of those sorts of things, but we haven't branched out too much into that space yet. But we're talking, of course, about alcohol, opioids, stimulants, cannabis, and vaping. And then some really specific good resources that are national resources that we always try to flag for journalists are these different organizations that are part of the federal government. So NIDA, which is the National Institute on Drug Abuse, has a number of really great resources related to the specific substances and addiction in particular. And then they, of course, hit on all of those things: prevention, harm reduction, treatment, recovery. NIAAA is NIDA, but for alcohol. So it's all of those same things, just focused primarily on alcohol. SAMHSA is a Substance Abuse Mental Health Service Administration, so that's also part of Health and Human Services. The NIDA and NIAAA are the research arms, so they do that part. SAMHSA is the translation and dissemination arm, so they take the research findings and try to put them in your community. So if you're trying to figure out like access to treatment, access to harm reduction, SAMHSA is the one that should have those things about how to do those things in your community. The DEA is a little tricky, admittedly, but they do have some accurate information about these specific substances, and they do some important work around drug seizures, of course, and also like the names of certain street substances. So if you're hearing about a new substance, they are usually on the cutting edge of that, because NIDA and NIAAA, those are really long tail sort of, it takes a while to get the grant, to do the research and whatever, where DEA is a little bit more cutting edge, but that can be a problem sometimes too, of course. And then the CDC, or the Center for Disease Control, also has a lot of information across those different domains. So if you're starting with a story about drug use or addiction and you're just trying to figure out baseline information, of course, you can reach out to us for resources, but these 5 resources are really great places to start. So if you search opioids plus NIDA, you're going to have a ton of really great evidence-based information to dig into that topic. We also like to do the definition of addiction, because this isn't a definition that all folks are always familiar with. And this is from the American Society of Addiction Medicine, which is a society of addiction medicine providers, of course. So those are MDs in the field providing addiction treatment. So addiction, of course, is a treatable chronic medical disease. It involves complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite the harmful consequences. And then prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So when we do longer talks and trainings, we dig a ton into this. So we'll do like a little bit of information about this, but if you have questions about these things, we're always happy to talk about them. And the colors aren't just because I like colors. They're also, we're going to break it down here for you for a second. So important here that addiction is, of course, treatable. And what we mean by that is that there's evidence-based treatments that are available and effective. And that's across all of the different substances that we just laid out, whether it's stimulants, whether it's opioids, whether it's alcohol. There's a ton of different treatment modalities. We could always use more. As a researcher, I know, and as someone who works with treatment providers, we're always trying to find and develop new treatments. And that's also really important. But there is a lot of stuff already available. So becoming familiar with those different treatment approaches as you're writing stories about addiction. If somebody talks about treatment, what treatment are they talking about? What treatment's actually available in your community? Those are all really great stories to run down. It's chronic in that it lasts a year or more and typically requires ongoing medical attention because it might limit activities of daily living, and that there's not a cure. So the chronic is really important. And when we're thinking about a chronic diseases don't have cures by nature. There's a lot of really exciting research in that space trying to develop cures or more durable treatments for addiction, but there isn't a cure right now. So why that's important, and Ashton will talk a little bit more about this, is when we're choosing our story arcs, we want to make sure that the end of the story isn't they got treatment and now they're cured, because there isn't a cure. So that's not an accurate representation of treatment. And that actually sets individuals up for failure because if we know folks in our community that receive treatment and then return to drug use, which is something that happens, right? Those stories about cures that are available gets us thinking, well, they got treatment. So what's the matter with them? Because I read that treatment cures this, or this specific approach cures this. And that, again, it's not accurate, and it really doesn't represent our understanding of treatment for this disease. Of course, framing it as a medical disease, so that treatment should be involving medical professionals and science-based approaches. So if you're writing stories about treatment facilities, or if you're writing stories about treatment providers, making sure and asking, what sort of approaches are you using? What evidence is behind those approaches? Do you have providers on staff? Do you provide access to medication? You would be surprised about the answers to those questions, because even though it is a well-established medical disease with all of these treatments that I'm telling you about, most facilities don't provide those. And so we have to really then step back and think, is this the type of facility that I want to write a story about? If it is, then making sure my audience understands, hey, they're a little bit out of step with the scientific evidence on this. And that's, again, something that we can help out with and help you connect with providers and other treatment providers and researchers in that area that can help flag some of those things. And then, of course, it's multifaceted. So there's not any one thing that leads to the progression of the disease or the development of the disease. There's the brain circuits, genetics, and the environment, and of course, an individual's life experiences. And so making sure our stories represent that full sort of picture. I don't expect you to write stories that include like neuroscience, right? But, talking about it, not just like person used drugs, then became addicted, then got cured. It's a very, very simplistic and inaccurate understanding of both the disease and that progression. So we want to add a little bit of nuance or complicate the narrative a little bit there. Okay. And I'm going fast because I know we're short on time. But the other things that are important with the definition is, of course, that continued use despite harmful consequences. This is a characteristic of the disease and not a personal failure. So like I said, whether it's treatment, and sometimes people return to use after treatment, depending on the quality of care, et cetera. But sometimes there are people that are in active addiction that are continuing to use drugs, even though they're experiencing a lot of problems in their lives. That is characteristic of the disease. That is one of the diagnostic criteria. That's something that we accept as part of how the disease manifests. Often it manifests in those external behaviors that are associated with drug craving and drug seeking, right? And so that might lead folks to, for example, not pick up their kids from school because they were out buying drugs, or miss a family event because they were drinking too much and they couldn't drive, or any of those sorts of things that we see as those problematic behaviors associated with drug use and addiction. That is, again, that characteristic of the disease, and not because they are a weak person or a moral failure. That's just how the disease looks. And then, of course, treatment and prevention work. I can't emphasize this enough. There's evidence-based treatments available. There's evidence-based prevention. And again, our stories want to make sure that we represent those things. And we're here to help you understand what are those evidence-based things for prevention? What are those evidence-based things for treatment? We connect you with those folks in your community or nationally that can help you understand those things as you're talking through it. Because we don't expect you to know all of the things that are treatment for alcohol, for example, and all the medications for alcohol. But if you're working on that story, you should really have that grounding that, hey, there are things more than just AA. There's medications available, there's cognitive behavioral therapy, et cetera. And then I like this quote. It's just that idea that the profound gap between the science of addiction and current practice is that result of decades of marginalizing addiction as a social problem rather than treating it as a medical condition. Most of what passes for treatment in our communities of addiction bears very little resemblance to the treatment of other health conditions. So that's obviously a huge problem. And it's part of why we're seeing the overdose death rates. It's part of why we're seeing just all of the problems associated with drug use and addiction, is because for so long, addiction was outside of medical care. And as it's been worked into medical care, we're starting to see those better outcomes, but it takes time, of course. And when you're talking to sources, or when you're talking to community members about finding treatment, or what treatment is, or there are issues with accessing treatment, those are all incredibly important stories. Those are all valid stories. But it's also important to take a step back and think, hey, does this look like the other health conditions that I report on, right? Were there health providers involved? So if I'm writing a story about diabetes, I would, of course, make sure, of course, that story is going to include an endocrinologist and other people on that team, right? We want to make sure addiction stories are also thinking through, or journalists that cover addiction also thinking through, like, did this include that medical care? Did this include that broader team of people that we know leads to better outcomes? Because a lot of what we hear from folks is, hey, I talked to someone and this is their 15th time going through treatment, and you're telling me treatment works. So like, what gives? And so again, taking a step back and like, was that actually treatment, or was that just that moral, social sort of blaming sort of oriented approach that doesn't actually align with scientific evidence that we have today? Okay, so quickly about stigma in journalism, of course. So addiction stigma is that, again, that pervasive belief that addiction is a personal choice that reflects that lack of willpower and a moral failing. And that you can see is diametrically opposed to that definition of addiction as a medical disease, chronic in nature, et cetera, right? And so a lot of the stories that we're seeing come out from the media or in popular representations, of course, really lean into this addiction stigma. So it's that willpower issue, that moral failing, that personal choice. And that's outdated, that's inaccurate, and that's really harmful for folks. And so we'll show you how the harm kind of comes through. So there's a few different types of stigma, none of which we need to care about today besides public stigma. And so this is that idea that, again, in the ether, that people who use drugs are dangerous, they're immoral, they're to blame for their behavior, right? Because it's a personal failing, and they are criminals. And so that stigma results in this discrimination against those individuals of our community. So therefore, it leads employers to not hire those folks, landlords to not rent to those folks, and that they should be shunned and pushed further to the margins of society. This public stigma and the narratives that we tell in our media stories is often perpetuating that public stigma. So it's telling about the dangerous, immoral, criminal aspects. So that's leading to this harm in our communities, that it leads to that discrimination, and it leads to that belief, again, that there isn't treatment available, that prevention doesn't work. Harm reduction is a political ploy. It's not real. It just further enables folks, right? And all of those things just further end up harming the folks that we're really trying to, again, represent accurately and empathetically with our reporting. So not that this is intentional, of course, and that's what we're here to help out with, is how to shift that narrative to be more accurate. And then, of course, whenever we're talking about stigma and discrimination, it's not just drugs, right? There's all sorts of intersectional elements that are important to consider when we're telling our stories. So as Katti said, I also do research with reproductive sexual health. And so I do research with pregnancy and drug use. If you think about stories that, and if you think in your mind for a second, like a pregnant drug user, most people will think those stigmatizing thoughts and beliefs align with stigma. They're immoral, they're dangerous, they should really be pushed away. Like that is the worst of the worst, a pregnant person using drugs. Like imagine how terrible that person's going to be as a mother, right? So that, those layers, and then you layer race on top of it, or you layer on the job that they have, or their religion, or their location, whether in rural Appalachia, or I'm from Michigan, whether in an urban center, right? And those stories, and they all take that really different lens on top of it and make it, again, where we're further discriminating against those folks, which isn't what we want. It's obviously not what you want with the stories that you're telling, but you always have to consider, when I'm telling this story about this individual, what is my audience perceiving about this fact that I'm telling a story about a pregnant person who uses drugs, right? And how can I tell that story accurately that doesn't cause that individual harm? And like I said, we work with a ton of people with lived experience, or experts through experience, as we call them. And they tell us all the time when they interact with the media, they get harm from it. They've lost jobs, they've lost housing. These are real harms that they experience because of how we report on these stories. So again, we can just be a little bit more careful and a little bit more thoughtful and accurate and empathetic. Okay.
Jonathan, I'm going to ask you to speed up just a tiny bit, just to make sure. Okay.
Yeah. So again, like I said, the current themes and language frequently dehumanize people with active addiction or in recovery. So we have to ask, how does this help loved ones, the community that we serve and the community that we're writing on, and those individuals with active addiction? It really doesn't. It ends up hurting folks. It pushes them to the margins of society. Addiction stigma kills people. That may sound hyperbolic, but it kills people every single day because it leads to all of those negative things. So we can do a lot better. And of course, we're here to help. Ashton, I'll switch to you.
Yeah, absolutely.
Ashton, before you jump, I need to correct myself, y'all. It's reporting ethically and accurately on addiction. I think I used the term opioid in my intro. Secondly, please put your questions in the Q&A. Adam, I do see your questions in the chat, but please put your questions in the Q&A. Thank you.
Okay, yeah, thanks. So I'll just share really quickly. At Reporting on Addiction, we have resources available to help you through all of the reporting process from pitch to publication. And I'm going to highlight a couple of those today, and highlight some of the resources that are available to you to go look for on our website that you can use and incorporate into your reporting. So on the next slide, we'll start with some of the questions that we'll ask you to keep in mind, whether you're a reporter or you're an editor who is guiding a newsroom. Some of these questions should be kind of in the back of your mind as you're taking on stories that intersect with addiction. What are the elements of addiction that need to be included in that story? And remember that kind of slide that Jonathan went through: prevention, harm reduction, treatment, recovery. All of those for us are elements of an addiction story. And so we want to make sure that they all get included when necessary, when it's appropriate, right? Not every story can cover all aspects. Make sure that addiction stories are rooted in the science and in the research. We have a question we'll get to about harm reduction strategies in the chat. There are decades of harm reduction research, peer-reviewed research that have been published about harm reduction strategies that are effective. The same with treatment, the same with prevention strategies. So rooting ourselves in the science is one of the most important things we can do to make sure that we are accurately reporting on this topic. Consider who are the real experts in this space. If you were doing a story about COVID and how COVID manifests itself in our bodies and how it impacts your community, your expert would not be the mayor. Your expert would be a doctor, a scientific expert, a public health official, right? So having those voices in our stories is incredibly important to make sure our communities can understand this as a medical issue and understand the solutions that really do exist for treatment, harm reduction, and recovery in our communities. Do we have to tell both sides of this story? Is it worth it to give space to or shed light on people who believe that addiction is a moral failure when really we know that the science proves otherwise? And anytime we are speaking to experts, we should be asking them what solutions exist for these problems that our communities are facing. On the next slide, I think we dig into a little bit more deeply about who our actual experts are. And I'll just really quickly touch on one point. At Reporting on Addiction, we believe that people like law enforcement officers, first responders, community leaders, they all have a role in our stories. But as journalists, if we want to accurately and ethically report on addiction, our responsibility is to keep those people in their lane. And so first responders is a really good example. If we think about what the definition of their job is, it is to show up when a person is having an emergency, to stabilize that person, and then to transport them to a hospital where they can receive the medical treatment that they need. And so absolutely, if you have an increase of overdose calls in your community, your first responders are the people who can talk to you about the strain on resources, the personal experience of having to respond to those influx of those calls, how it impacts them emotionally, mentally. But they are not the people to explain to your audience what addiction is and how we solve or treat this disease. So again, when it comes to our sources, keeping people in their lane and understanding what their area of expertise allows them to speak to. I think we're jumping into now a couple of just things to keep in mind. Remember that every person's path to recovery is valid, but no one's experience is universal. And we often as journalists fall into this kind of trope of telling one universal story, or we want our stories to be clean and neat and tied up with a little bow. But every individual experience when it comes to addiction, when it comes to recovery, it is always different. And so this what we're attempting to show here is the many, many paths for treatment and recovery that can include things like detox, inpatient treatment, a residential rehab facility, or an outpatient program. They can include individual therapy or support groups. It could mean something like AA or NA. All of those are valid paths to recovery, but every individual experience is going to be different. And so we need to remember not to push back against somebody who is telling us their personal story, but incorporating the science into the reporting that we're doing long-term. We can go to the next one. So while you are writing, yes, you collected it, but should you use it? This is especially important when it comes to the anecdotes and quotes and the photos that we're taking in the field. We at Reporting on Addiction believe you should absolutely collect everything while you're in the field. Collect it all. But then you need to sit down and consider the impact of every single word, every single story, every single frame of video is going to have on this community of people. it is very often that somebody who is maybe in recovery or in active addiction is suffering from internalized stigma and shame. And they will say things about themselves like, oh, I was just a junkie, or I have no value, or I'm not important, or I'm just an addict, right? I'm just an alcoholic. The thing is, those words hurt people other than the individual. They create and they perpetuate public stigma that continues to create barriers for access to care and treatment in our communities. You have a responsibility as a journalist to recognize and understand that bigger impact and to adjust your reporting and your storytelling based on the stigma that can persist through your narratives. If you sat down with somebody to do an interview and the only quote you collected from them was, oh, I'm just a junkie, and you didn't spend any more time with them or collect any other quotes, then you didn't do your job very well. There are always other quotes. There are always other things that you can use. And so we have the ethical imperative to consider what the larger and broader impact of those terms are for the community that is larger than just this one individual. Remember, there are 25 million people in recovery in this country. Those people are in your audience. Those people are in your communities. And by continuing to use these stereotypical or stigmatizing stories and languages, we are actively pushing people away from our news. We're actively pushing people away from reading or listening to or watching our stories. And I know that you all don't want to do that. So think about every word, every quote, every visual that you collect. You can go next. I will share this with you. This is about some of the language in the spaces. This is a study that was done about some of the language that was used and where it's available in perfect space or in specific spaces. You can see very quickly, though, that words like addict, alcoholic, people feel comfortable using those terms in mutual aid settings, so things like NA or AA meetings, but they don't feel comfortable with anybody else using that terminology about them. So we have to, as journalists, consider and understand the implications of those words and those narratives. So resources really quickly that are available to you. We have a language style guide that we put out when we launched 2 years ago. You can find it at reportingonaddiction.org, or that QR code on your screen will take you there. Checklist for responsible reporting is going to go over in more detail some of the things that we discussed today. On the back side, you will see a chart that's basically a say this instead of that kind of thing. And what's important for you all to remember here is that we have incorporated the rules from the Associated Press. They updated their style guide with resources for covering addiction in about 2017, and those rules seem to not have made their way into the journalism itself. So we didn't just decide these things. We've incorporated the Associated Press style tips and also added some context with some additional research and some focus groups that we did ourselves to help inform this. On the next slide, you have access to the visual style guide. So we just created this and put it out in September. Structurally, very, very similar, some checklists for responsible visual reporting. On the back side, we get into some more specific details about, instead of a photo like this, you think about using something like that. Instead of video showing this, think about using something like this instead, and the rationale for those decisions. Again, I think it's important just to recognize that Jonathan and I just didn't decide. This took 18 months for us to create through the work of experts through experience. So doctors, clinicians, scientists, those are experts through training, experts through experience, people with lived experience, family members, peer recovery coaches. We also worked with journalism educators and working photojournalists in the field to create this so that it's not just a, hey, stop doing this thing, but a realistic view on how you can improve your reporting in a real newsroom. We, of course, have ideals that we would love for you to do, but there are specific things that are realistic about your jobs as well. Jonathan mentioned we have an expert database. I think we have about 90 plus people in this database right now that is searchable for you via city and state, and also their area of expertise. These are folks that we have vetted. I shouldn't say we, Jonathan has vetted. He's spent a lot of time recruiting researchers, clinicians, scientists, people with lived experience who recognize the importance of the journalism and have agreed to answer you quickly. So they are both experts in this space and also know that journalism happens fast and they want to help you do that. So QR code will take you there, and you can also find it at just reportingonaddiction.org. And finally, if you take one thing away from today, please take this with you. I'm sure that everyone saw about a year ago those stories about the new 988 phone number. Every time you heard that story on the radio or saw it on television or saw it in the newspaper, there was a sentence that said, if you or someone you know needs help, right, call this phone number. Well, there's no reason why people who are struggling with addiction can't also access the treatment and the resources that they need. So we're asking you to use this sentence, save a little bit of space at the end of your digital version of your story, give it to your anchor to read after your spot at the 5 o'clock news, whatever it is. These are federal resources. If you know your state has resources and you'd like to swap out that phone number for your state resources, that's great too. But this does two things. It allows you to give people hope. Even if your story is, you were assigned to report on the latest CDC numbers, overdose numbers, adding this sentence at the end gives people hope. But it also takes away the responsibility of you as a journalist to find help for your sources. And we heard that from a lot of journalists as we were creating our resources initially, that I feel connected to these people. I feel deeply for these people. I feel empathetic in these situations, but I cannot help them. It is not your responsibility to find someone a bed, but you can give them this information and get them to the people that they need who can help them with those things. So recovery from addiction is possible. For more information, and then there's an email address and a phone number for you. And then our final pitch for you is Jonathan and I are going to launch a micro grant here on December 1st, and we're going to be taking applications through the end of January. If you are someone who wants to do a story on prevention, treatment, addiction, harm reduction, recovery that complicates the narrative of these stories, we have 3 $750 grants for professional or freelance journalists, one $500 grant for a student journalist if you know someone or you work with a student newsroom. These will be stories that you'll be working on with us and within your newsroom by May 31st of next year. We will be announcing and sharing the application on Friday. So that QR code takes you to sign up to our newsletter, where we'll be sharing all of that information with you at the end of the week. So a little bit of a plug, but those micro grants are going to be available for you, and we would love for you to come join us in doing some of this reporting. So Katti, that's it from us. I want to throw it back over to you and we can get to questions.
Sorry, slow on the draw. I have a million questions. This is so rich. I want to start here. Who should be on this treatment team as a first sort of gauge of the legitimacy of a treatment program? What should journalists be looking for? Who should be the members of that team?
So
yeah. Sorry, I was just gonna say, so I think evaluating the overall program structure. So usually you would have some sort of medical provider that also is providing medications depending on the type of condition, and that they're also addressing other sort of mental health conditions that may be occurring at the same time. So that it's not just, when we think about addiction, it usually intersects with a lot of different things. So we're not, of course, those treatment facilities shouldn't just focus on addiction. So making sure that they're multifaceted and that they have at least some treatment providers that have prescribing ability. So that can be MDs, nurse practitioners can also prescribe the medications. Physicians' assistants can now prescribe those medications. So just making sure that they're doing that and asking
physicians' assistants everywhere in the country, the PAs, or just in some states?
I don't know if that's state level. I think that is national, actually. I can look that up, Katti.
Or we can look it up.
Yeah. I don't know. Anyway, so yeah, making sure you check that. And then also when you're evaluating like the website, some websites are very straightforward and say like, yes, we offer this medication. Some also will say like, we do not offer any medication at all, or that's just like not our thing. Here's what we do. So that's also a really good first pass if you can't tell. Also just calling and saying, doing like a simulated patient, like, hey, I'm looking for treatment, what's available? And you'll learn a lot about how they actually treat folks.
Anne, thank you for that answer. Anne McManus says every state allows PAs now.
Yeah, that's what I thought.
So, and my second question is really kind of personal. My brother was an addict, long time, and I got to a point as I sort of grew, as I say, addicts don't want to be addicts; they just are. Because I loved my brother so fiercely, and this was a long time ago. I'm wondering the extent to which families feel empowered and are reframing that, who don't say what I said, which was an oversimplistic. And my brother had been in and out of treatment. I never thought people relapse, right? Like that whole notion, how are families sort of reshaping this discussion, this language, what happens in medicine for their relatives?
Yeah, I'll let Jonathan talk on what's happening in talk about what's happening in medical spaces, but I just want to touch on what's happening with families in journalism spaces. I think we very often see, at least in the work that we are doing, every time we go into a community, we try to bring people in to meet with journalists and talk through what's complicating, how the storytelling is complicating the work that we're doing. And we're almost always seeing families take the forefront of these conversations, leading these conversations in communities. I think as journalists, we have to be incredibly careful that we recognize the trauma that these families have experienced. Whether they have lost a loved one, they are the family member of someone who is currently in active addiction, or even if they have someone who is in recovery as part of their family and they want to speak out, we as journalists need to incorporate those kinds of trauma-informed reporting methods into the work that we're doing. We have to recognize the intense trauma we're asking families to recount for us as they share their stories. And there are plenty who want to get the word out, who want to talk about their experiences, who see that as a way to save lives. So absolutely, their stories are important to tell. We have to be cautious with how we're handling their stories and make sure they understand everything that they're agreeing to. The story is going to exist forever. We're always going to know who you are and your family's story. It's going to be on the internet always. I'm going to ask you to recount these things in really difficult depth. Are you sure you're willing to do that? And then making sure that we're handling those conversations with care.
Yeah, and I'll just add quickly, and Ashton, I agree with everything Ashton said. We also want to make sure that when we're telling those stories about family members, that we include those other types of experts. So again, those family members aren't talking outside of their lane, because families aren't experts in what treatment is. What they know is their individual experience with trying to find treatment for a family member. And oftentimes we see them talking about, hey, I had to send my kid to Malibu and do all this stuff because either there wasn't treatment available or they weren't aware of the different types of treatment that are actually available for them in their local community, because we don't tell those stories, right? And so it leads into this feedback loop of the only way to get treatment is to send my kid to Florida to get treatment because of, right? And so we want to make sure that if we're telling those stories about family members and their difficulties across the spectrum, that we're also grounding it in the reality of finding treatment in our community, what the medical providers are saying, et cetera. And Adam, I agree with your point too. We don't do a great job of talking about families in long-term recovery, we really just talk about them with like, they had a dead person in their family and then like, we kind of move on.
And you saw one of the questions from Adam in the chat. I want to combine it with the question he followed up with. The first one was, does everyone agree with the medicalization of problematic drug use? And the second part that's in the chat is this: is it more properly a public health policy and practice issue with social, spiritual, as well as medical dimensions, et cetera?
Yeah, so that's a really great question, Adam. And what we're talking about is not problematic drug use. We're talking about drug addiction, which are two different things. So problematic drug use might be I have problems associated with my drug use, but I don't meet criteria for addiction. And we can, of course, talk to you a little bit more too about like how to distinguish those things, but there are diagnostic criteria, et cetera. So that's a separate issue, but it is like related in terms of how we talk about folks who use drugs broadly should also fall under this framework of person-centered, of accurate, of empathetic, right? anybody who uses drugs deserves the same honor and dignity as somebody with an active addiction. So I'm not saying like don't apply any of those lessons, but the medicalization of problematic drug use isn't really what we're talking about. And then in terms of public health policy, yeah, of course, it does intersect with all of those different domains. And when you're talking to folks, they will talk about those things. Researchers, when we research them, we're not just focused on medication development. We're also focused on how it interacts with their social environment, how it interacts with their other medical diseases or conditions. And then, of course, spiritual elements, if those resonate for individuals. So we're, again, doing like a super quick one, but addiction itself is super complex, and it hits across many different domains associated with health and well-being overall, like sleep, like sexual function, like spiritual function, social functions, et cetera. So it is very complicated. It's not just about medical, but medical is also not just about medical. Medical also includes social function.
So this question is about the infrastructure. How sufficient or not is the treatment infrastructure? Who gets treatment? And then I want to add to this, this is Margarita's question. Where can journalists go to find information about state funding for prevention and recovery programs? Is there an organization tracking that, as well as laws that may limit or broaden eligibility to access to government assisted treatment or government assistance for treatment, funding for treatment?
Yeah, so it's a great question, and it's a multi-part question. So I'll try to do it. In terms of the gaps around treatment, they are significant. So I think that there's a lot of really important stories that we could be telling as journalists about what does treatment look like in my community. How easy is it for an individual to actually reach and access those treatment resources? You would probably not be too surprised, but it's really, really, really hard. And so we want to make sure that, again, we're representing that, because that's the only way policymakers can identify, hey, we don't have providers in this part of the area, or it took 15 days to get into treatment. And when we think about drug addiction, those 15 days, I'm not just like sitting at home not using drugs. I'm continuing to use drugs, which is risky, and all of those things, right? And so trying to find those access stories are really important. That findtreatment.gov resource Ashton shared, if you're a journalist, if you just pull that up, search your community, and try to figure out how to get treatment, again, it's a lot harder than you would imagine. And so then if you put yourself in the shoes of a family member or a parent or whatever that's also trying to find treatment, again, it really helps to represent that, like, this is kind of a mess still. For NIAAA, there's another treatment resource available that I'm blanking on right now. Gosh, what is it called? I can't think of it. But there's also one specifically for alcohol that does a really nice job that lays out all of the different ways that you can interrogate and understand whether treatment's actually treatment in that facility. So that's a really good one. I will think through. Like I said, I'm just a little fried with this morning or afternoon. Okay. And then the other question, Katti, that you had was about state funding for prevention and recovery programs. That's all state by state. I don't know if there's a national organization that tracks that sort of stuff. SAMHSA should have a good sense of where some of that money is going, because SAMHSA does fund those grants in those communities. So if you go to SAMHSA and you look at the different block grants, is what they're called, you'll be able to see, is there a SAMHSA block grant for whatever state that you're in, Margaret, and understand like who's getting that money and then how it's actually being implemented in the community is one way that I would approach that story. But we can definitely talk to you more about that if you have a specific story in mind for how to find that sort of stuff. And then trends by race and ethnicity is a disaster. So we continue to see like really big problems around access broadly, but access in particular in BIPOC communities. Then I treatment navigator. Thank you, Ashton. Access in BIPOC communities in particular is really, really challenged still across all of the different substances. And
challenged in what ways? Is it a matter of money, of white people get priority? I don't know how to say it any differently, but what? Challenged in what ways?
Yeah, it's multifaceted. So some of it is like, are there providers available? And if there are providers available, do they have room for new patients? Are the different approaches being offered? So for example, if I am in Ann Arbor, methadone is not available in Ann Arbor, which is a mid-sized city, I would say. There's only buprenorphine, which is fine for opioids in particular. But, we want to make sure there's multiple treatment options available, because some people like certain things or some people respond better to certain things, right? So some of it's that. And then some of it's just like access issues. So whether it's transportation, whether it's insurance coverage or billing, any of that sort of stuff. And then something as simple as like filling the prescription. A lot of pharmacies don't stock these medications. So even if I get a prescription, it's really challenging then to fill that prescription. So you got to think about it across like the whole lifespan of an individual interacting with the service. There's gaps across all of them, and there's enhanced gaps if you're in a BIPOC community or rural community or any of those other sort of communities. Sorry.
Why don't they stock the pharmacies? Why don't they stock these medications?
I don't know if, are we done in a minute?
I'm just asking Catherine, can we go over a few minutes? I was just sending her a text. Kat, can we
go right ahead. Go over.
Okay, great. Because
okay.
Go ahead.
Yeah. So there's some cool research on this that are like secret shopper studies. And so basically what I do is pretend to be somebody trying to access that medication at the pharmacy, and you call and see if that medication is available. The pharmacies might not stock it for any number of reasons. Some of it is just like supply chain shit that we're still running into from COVID. So some of it's that, like ADHD medication. That also has been said is impacting some of these medications for treatment. But there's also pharmacies that are scared of stocking the medication because they don't want those patients in their pharmacy because of that stigma and discrimination. And then they're going to get any of the things that are associated with that. And then some of them don't stock it because they're scared of the DEA, because the DEA has been very inconsistent on messaging around the treatments and has been really very harmful about their messaging. And so some pharmacies are scared if we start to stock it, the DEA is going to come in and shut us down like they did with some of the opioids back in the early 2000s when they were overprescribing that. So it's just a misunderstanding of like the medication and how it works. But pharmacies are obviously scared because they're multi-billion-dollar lawsuits that they're facing. And so instead of just like trying to wade into it and trying to figure it out, they're just kind of staying on the sidelines for some of them. So it's again, complex, but there's a lot of good stories there.
Can we talk about language just a little? And I know y'all have a guide on that. I mean, I use the term addict when I talk about my brother. It's not meant to impugn or anything. The term addiction versus substance use disorder, which many journalists use. So I wonder how that should be weighed, how we weigh the varying of language, because the journalist will say, I can only say that so many times. And I wonder, frankly, the extent to which substance use disorder reduces the gravity of the problem, if that's a fair thing to ask.
Yeah, and thank you for asking that, Katti. And Ashton, do you want to start, or do you want me to?
I mean, I don't mind to start. I'm sure that we're going to say the exact same things. What we know is that substance use disorder is the medical term, right? That is what doctors are actually assessing and diagnosing people with. The research that we have seen, the research that we use does not show that addiction creates any additional stigma. That's why we are okay with calling ourselves reporting on addiction. If we believe that it was harmful and it created additional stigma in our work, then we wouldn't have done that. But so far, the research doesn't bear that out. So addiction is a term that is easier for our audiences to understand. And so I know that, and I was in a newsroom about 10 years ago when that push for using substance use disorder in our narratives really kind of came through newsrooms. I don't think there's anything wrong with using that term. It is the medical definition of the term, but addiction is the same, right? And it is easier and it is just as useful and does not create stigma in our reporting. So in a newsroom where you have an editor who is pushing back against substance use disorder, addiction is a perfectly fine term for you to use. Or in the opposite way, if they are pushing back and saying, no, we must use opioid use disorder, alcohol use disorder, that addiction is perfectly fine for you to use as well. That's at least what we're seeing from the research.
Yeah, I agree 100%, Ashton. Oh, go ahead. Sorry, Katti.
And you can address maybe the term addict, which frankly, at some point, if I'm doing a 4,000 word piece, it's going to fall into my story. Probably. Would y'all address that?
Sure. Yeah. And so just to reemphasize what Ashton was saying, it's really audience specific. Addiction and substance use disorder are interchangeable. And it's what you think your audience understands about the concept. And we also know like substance use disorder is just a long phrase. People don't really know what it means. Where people understand intuitively what an addiction is. There's something that pops in their head. it's probably wrong, but at least something popped in their head. Where a substance use disorder, you have to explain. Now, the word addiction and addict are completely different, right? And so addiction is not shown to be associated with harm, where the phrase addict is shown to be associated with harm. And so what we mean by that is there's research in the space that when you tell a story about somebody that is a ex-addict, or just like whatever substance addict, versus somebody with a substance use disorder or somebody with an addiction, it does change how somebody perceives that individual in the story. So stories that refer to people as addicts lead to higher endorsement with stigma and discrimination. So I don't want that person around. That person shouldn't have kids. That person shouldn't have a job. That person shouldn't be around me or my family. I don't like that person. And when you frame it as a person with an addiction or with a substance use disorder, we see a decrease in all of those things. So
even
overall,
if you're doing this long form piece, that word addict is detrimental.
Yeah, there's no reason to use the word addict at all in any of our writing because of the harm associated with it. And where I will say it's very similar to other sorts of words that we don't use to describe groups of people. So there's words that are derogatory to describe LGBTQ populations. Like we wouldn't write those words in our reporting or in our narrative unless it was like a politician called somebody this, right? Or there's words to describe BIPOC communities or any sort of ethnic community that are like slurs. Consider addict in the slur category of a word that like there's no reason to use that word. It is associated with harm. It only further harms that individual and their community. And there's just no reason to ever use that word in any of our writing. And that's borne out both through the research and also talking with people with lived experience. And again, like Ashton pointed out, some people will refer to themselves as addicts, but even as they're doing that, they're doing it in a way to say that they are less than or other and lower than other people, which is not what we should be representing in our stories and when we talk about people, because we should provide them all respect and dignity.
Last two questions. One, Margarita, is who are the journalists that you follow, whose work you love, whose framing you love?
Aneri Patani is my favorite right now.
How do you spell that?
Yeah, so I'll drop her name in the chat. Aneri is working over at, oh gosh, they just changed their name. Is it still KFF Health News? Is that the new name?
I think that's the new name.
Okay. So, well, everybody, I spelled her name wrong. I apologize because I was trying to talk and type at the same time. So Aneri is over at KFF Health News, and she started over the summer and has committed a full year to reporting on the opioid lawsuit settlement money and how that funding is being spent in communities across the country, and has also created some resources to help journalists who are also considering covering that topic. And Aneri is doing a really fantastic job, highly informed in mental health and suicide reporting as well. And a member of AHCJ. So Aneri, I think, is one person that I'll call out she's doing really, really great work right now.
And this is the last question, because I was struck by it when we talked before, this notion of cure, not being cured, which I'll just peel that back in this particular sphere, because there are diseases that people are cured from. Why not this?
Yeah, so there aren't chronic diseases that we have cures. And by nature, a chronic disease doesn't have a cure like diabetes. So we have things that we can do with diabetes that are that ongoing chronic disease maintenance. I have a chronic disease like rosacea. And when my provider diagnosed me with it, they're like, hey, this is chronic disease. Here's what we're going to do. We're going to treat it over the course of the rest of your life. So addiction, as of right now, looks the same way. And the reason for that is because of those structural and functional changes initially to the brain associated with drug use. So that's that medical part, but there's also that social, environmental, stress, all of those other things that are, again, associated with drug use. So because of that, because the return to use is always a potential for individuals with an addiction and individuals with an addiction who use drugs, even 15 years after they last used that drug. Because they're wired slightly differently, their genetics are slightly differently, their receptors are different. So things that actually like interact with the drugs in their body, all of those things are different. And so when they interact with those substances, that path to continuing to use in a problematic way, it's just those wheels are greased a little bit differently than for other folks. And so that's why we consider it a chronic disease. And again, if you line it up against other chronic diseases like asthma, like cardiovascular disease, like diabetes, it looks almost exactly the same. And so Ashton likes to say, and I don't think she did today, but if you're a reporter and you're covering the topic and you're writing on this disease of addiction, if you sub out the whatever drug addiction you're talking about for cancer, for diabetes or whatever, and it reads as very moralistic, very blaming, then you can tell like, hey, I need to take a step back and reevaluate how I'm writing this story. That's a really good rule of thumb that we like to tell journalists. If you just sub out other medical diseases, you'll see that there might be some problems with how addiction is being used in your story or other people's stories.
And that begs the very last question. What is treatment success? You mentioned that. What is that? Define that.
Oh, did I say treatment success? So what I mean by
treatment
success... Oh, okay. That's okay. So what I mean by treatment overall is a reduction in the symptoms associated with drug use and addiction. So that's an increase in quality of life and overall functioning. And I know that like sounds super capitalistic, but it's just like an overall ability to function in your environment in a happy and healthy way. So that's what we look for in treatment success. And that might mean for some people ongoing medication to treat that addiction, ongoing therapy to treat those addictions and the other things surrounding it, right? So it might look like those things like we see with other chronic diseases. There's a lot of people that have been being treated for opioid use disorder for 20 plus years, 30 plus, 40 plus years on methadone, for example. That's treatment success because it's reducing all of those harms associated with the drug use for those individuals. Just like taking insulin is treatment success. If you're taking it daily, like you're supposed to, your A1C is in a good spot. All of those things that we measure are markers for diabetes. Similarly with addiction, we want to have all of those different behavioral markers. If we're kind of nailing those things are going great. That's treatment success. Now, we also can frame that as long-term recovery. And some people use that language because treatment is, again, ongoing and intersects with recovery.
Jonathan Stoltman, Ashton Mara, this has been a really rich conversation. I learned a lot. I know we all did. Thank you so much for your time. I will be in touch because I have some stories I want to pitch. Appreciate it. Thank you so much.